Hello, this is Dr. Grant Cooper from Princeton Spine and Joint Center in today's office hours, where we address the questions that you've been sending us in on YouTube and on email. Thank you for those. So today's question is about leg length discrepancy. Specifically, the person was asking about leg length discrepancies in patients with scoliosis and how do we address those. But the question of leg length discrepancy comes up in a variety of circumstances, and it's something that a lot of people wonder about. So let's talk about that. My general feeling when it comes to leg length discrepancies, and I think most doctors would echo this, is that a lot of times the way that that comes up is somebody will have will develop back pain or hip pain or knee pain, and they'll come in and as part of the exam, you'll notice that there's a leg length discrepancy. And assuming that it's relatively mild, maybe a centimeter or even two sometimes, uh, you don't necessarily want to go addressing that, right? Because the thing about a leg length discrepancy is that it's probably been there for a long, long time. Um, and as long as there's no reason to suspect that the leg length discrepancy is new, for example, in somebody who just had a hip replacement and now all of a sudden there's leg length discrepancy, that's a different situation. If it's more of a chronic problem and we're just noticing that there seems to be this discrepancy, if we go in and we start addressing that too aggressively with a heel lift or something else, some other kind of lift, the problem is that we're taking a biomechanical situation that the person has become accustomed to over the course of 10, 20, 30, 40, 50 or longer years. And now we're changing it. And so now we're adding in this extra variable. And a lot of times when we go doing that, especially if we're doing it aggressively, then we start creating a lot more problems than we're solving. Now, sometimes if someone comes in and they have a new problem and you notice there's a real big leg length discrepancy, and we all have slightly different margins for that. I would say if it's an inch, if it's 2.54 centimeters or more, you might want to you might want to start correcting that a little at a time. You probably don't want to correct the whole thing right away, but you might want to correct half of that or a third of it, and slowly start to see if that makes a difference for the person. If it starts to create more problems than it's solving, then you probably want to back off of that and recognize that leg length discrepancy has been there for a long time. The person has been fine with it for a long time. And so there's no reason that you necessarily have to run in and go addressing that right away. It's a different situation if someone's had a recent, like a trauma or a hip or a knee replacement where there is a new leg length discrepancy, then you are going to want to address that a lot more aggressively and a lot quicker. This one was about my thoughts on acupuncture. It was kind of a general question about, I guess, acupuncture as a general approach for musculoskeletal medicine. And it's a great question because it really comes up a lot. When I was, it's got to be 12 years ago or so now, I think, maybe longer. I did a book titled Acupuncture for Spine and Musculoskeletal Medicine. And basically what we did with that book is we reviewed the scientific literature that either supported or refuted acupuncture for various musculoskeletal complaints. And what we found is, in general, there's not a lot of scientific evidence for acupuncture for a lot of different musculoskeletal conditions, but there is some. There was a surprising amount of studies for things like knee osteoarthritis. But as a general principle, I think that acupuncture is generally safe. In good hands, it really should be quite safe. It should be relatively enjoyable. I think that, you know, I wish that acupuncture were covered by most insurance companies. I think it would be a great adjunctive care. And if it were covered, I'd probably prescribe it for anyone who's interested, really, because I think it can only be a force for good. With that said, for a lot of spine and musculoskeletal conditions, it's certainly not evidence-based, generally speaking, for most of those things. There's usually better conservative, like evidence-based care that one could go to if they want to. But I think that, generally speaking, it's a safe modality. Sometimes it works much better than any medical doctor is going to think it's going to. And yet, I think that it needs to be, viewed with a fair amount of circumspection because it doesn't have the data behind it. But now I'm going in a bit of circles. I think as a general rule, I wish it were covered. I think that it's generally a force for good. I wouldn't tend to use it in replace of better evidence-based care, but as something alongside of, or as something that someone just wants to try, realizing that there are other evidence-based cares out there. I think that go for it. This question was someone who wrote in and said that they have pain when they're bending forward and pain when they're bending backwards. Is it possible that they have more than one problem going on? And then the question went on and asked about degenerative disc disease. And the answer is absolutely. So it's a really great point. It's one that we wanted to highlight because we end up talking a lot in these videos and in conferences and in books and with patients about individual pathologies that can happen. Like, in the lower back, the three most common would be, disc pain, facet joint pain, which are those little hinge joints in the back of the spine, and sacroiliac joint pain. Those are the three most common causes of chronic lower back and buttock pain. But of course, that doesn't mean that someone can't have more than one problem going on. They absolutely can. It's one of the things that you need to tease out with the doctor. Sometimes when you do a diagnostic block to try to figure out what's going on, we'll block, for example, the facet joints. But one of the things that we're careful to ask the patient is, when you're telling us how you feel after we've injected one of these spots, the facet joint, for example, if one part of the pain goes away completely, but one part of the pain is still there, then tell us that, because what that tells us is that one part of the pain is coming from the facet joint and the other part of the pain is going to be coming from something else, not the facet joint. So sometimes you have to peel it back like an onion. And sometimes, it'll just be that if someone's had, let's say, degenerative disc disease for a while, which is usually more painful when you're in flexion, when you're bent forward, when you're sitting, but the muscles tighten up over time because they've been guarding, and now every movement starts to hurt. But ultimately, the underlying problem is still going to be the disc. But sometimes it'll be that the disc was painful. It made people move differently, start to put pressure in different ways, and then they started getting other problems like facet joint pain in their back as well. So it really just depends, but it's absolutely a very important point to keep in mind that someone can definitely have more than one problem going on in their back or their neck, and that sometimes those symptoms distributions can overlap. So it's important to keep that in mind, and just work through it with your doctor as you're arriving at a diagnosis, which of course is the most important step in treating the problem. Thank you so much for the question. Please keep those questions coming in, and we'll see you in the next office hours.